Hello, good afternoon. To all who are new here, welcome. You're here for Releve Sports Medicine's Journal Club, providing continuing education credits for athletic trainers. Due to the COVID-19 precautions, the BOC has allowed us to move our regularly scheduled journal clubs to an online platform. Fortunately, our fearless head of the journal club and liaison with the BOC, Brittany, has been doing an excellent job at making this a seamless transition. For all of those athletic trainers who are attending and do intend to get live CEUs from the BOC, immediately after the webinar closes, there will be a quiz that pops up to be completed. This will become available once the webinar is finished. You do have to stay through to the end in order to have that pop up. In order to access the quiz, make sure you're still here at that point. Next, 1 hour after the webinar concludes, you'll be emailed a link to the evaluation and the assessment. You will have 24 hours to complete the assessment. Once you've completed the quiz and the assessment, you will then receive your statement of credit via email within 2 business days. If you have any questions during the webinar, please submit the question and we'll review questions at the conclusion of the presentation. If you would like to do a live question, you can use one of the buttons to raise your hand, and Brittany will assist me in making sure that we can get to as many questions as we have time for. So to begin, we are going to be talking today about environmental exposures and viral outbreaks, which is certainly very timely with everyone social distancing. My name is Michelle Henne, and I am a sports medicine physician at Releve Sports Medicine in Winter Haven, Florida. There you go. All right, so I did a combined 7-year program for my bachelor's in medical school at University of South Florida. I attended Bayfront Health Family Medicine residency program, followed by a sports medicine fellowship at the Orlando Health University of Florida program, and then started Releve Sports Medicine in 2017. I have no relevant financial relationships to disclose. Here is an outline of what we're going to be going through today. A lot of exciting things. To break it down simply, we're going to talk about heat, then we're going to talk about lightning, and then we're going to talk about viral outbreaks. So what are our objectives? We want to be talking about how to construct a differential diagnosis of exertional heat-related illness, classify the management into urgent and emergent, review the clinical presentation of those affected by lightning, formulate emergency action planning for lightning during an athletic event, and then clinically assess and triage a viral outbreak in the training room. I always like to give people a quick and easy pearl to take home with them. And today that one is going to be, what should we be thinking of? What's kind of the quick and dirty assessment of if you find someone down or someone goes down in the middle of a game, in the middle of an event that you're covering. And those are the 3 H's: head, heat, and heart. So if they have just had a head collision or had a very recent head collision, we can certainly go down that path. If they have a pulse, then it's not the heart. But if neither are the case, then we certainly do want to make sure that we have evaluated them appropriately for heat. And why do we want to talk about heat? Well, from CDC data collected from high school sports-related injuries, which this NEISS is a very large data collection of sports injuries, and it happens to be in the high school setting. What we know is that heat injuries do occur, and the vast majority of heat injuries do occur in August. Football it is the most common sport for heat-related injuries to occur in, but that doesn't preclude other sports from having heat-related illness. How do we modify our body temperature, and how is the environment impacting our body temperature? Well, there's conductive heat loss that occurs from direct contact, convection with air circulation such as wind coming by, radiation that's coming from the sun, the electromagnetic waves, evaporation through our own sweat, And then above 95 degrees, there's no conductive or radiant heat loss, and there is heat gain going on from solar radiation, which does increase. Now, how is that different from acclimatized individuals? Acclimatized individuals can have asymptomatic core body temperatures that are elevated during exercise without having any other heat-related illness. So how do we measure thermal load? And I have an example here of one type of a wet bulb globe temperature. There are a variety of different types that are out there, and there are also now applications that I would say are sometimes used even more frequently that provide you access to that composite information for your location. Now, what comprises the largest amount, and you'll see this information later, what comprises the largest component of that wet bulb globe temperature? And that's humidity and air velocity. Those components are 70% of what makes up the wet bulb globe temperature, whereas something such as the air temperature only comprises 10%. So the humidity and air velocity do make up a big component of the thermal load. What are ways that we can prevent heat-related illness? And this comes from ACSM. And that looks at those wet bulb globe temperatures and modifying our activity based on not only what the activity is, but also the acclimatization status of the athlete, as well as whether the athlete is a high risk or a low risk individual. So at and around that 82 degree temperature, that's where we really start getting more critical of who can and should be participating, or if this is an activity that we should consider suspending until the environmental conditions are more safe for all of those participants. What are other ways besides looking at the temperature specifically that we can prevent heat-related illness? Well, our clothing is certainly an important component. A gradual introduction of football equipment, as well as utilizing clothing that allows for a good evaporation and conduction of those heat. So how long does acclimatization last? It does typically take 10 to 14 days. So that is a good time period when you're talking with your football coaches, for example, at the beginning of the season, or you're talking with your hockey coaches even, when you're talking with the coaches about how long we want to make sure that we're doing a preseason acclimatization time period, getting our athletes who may have not been doing a whole lot or as much during their break, getting them back and up to speed so that they're ready to go 100% come game day. We want to monitor those environmental conditions, and then we want to treat those chronic medical conditions appropriately. What does that include? Particularly athletes with fever or illness. I like to talk about the neck check, and that refers to symptoms. If symptoms are occurring above the neck, meaning congestion, eye-related symptoms, ear-related symptoms, those are folks, and you certainly want to discuss this with your team physician, but those are folks generally that if they're able to tolerate a warm-up and they don't have worsening of their symptoms, then those can be ones that may be able to participate. On the other hand, if they're having symptoms that are below the neck, that's going to be the cough, the shortness of breath, the nausea, the vomiting, the diarrhea, or the fever, which is a systemic symptom. Those are ones who should be withheld due to their risks, their increased risk for heat-related illness. How else can we do it? Well, certainly our hydration. And I know that you guys as athletic trainers are always talking about the hydration. This is something that I do like to bring up during the pre-participation physicals with my athletes, talking about monitoring your thirst, monitoring your body weight, and then monitoring your urine color, making sure you're in that clear to light yellow range. Looking at rest periods between either between 2-a-day workouts or time periods between, let's say they're doing weight training in the morning and getting on the field in the afternoon. Avoiding exercise as a punishment and avoiding novel overexertion. So the NATA position statement on exertional heat illness has a variety, has a very large list of ways that we can help to prevent the heat-related illness, because that's realistically what we want to do. We want to prevent it, and then we certainly want to be aware of how to identify it and treat it when it does happen. What I want to emphasize now is the PPE. And so coming straight from that position statement, one of the biggest things that goes into identifying who's going to be your high-risk athletes is understanding what their history is. If they have a history of different types of heat-related illness, whether it's exertional heat stroke, heat exhaustion, etc., these are your athletes that you want to be aware of. You want to make sure that your team physician is also aware of these folks. And you may even consider, based on their circumstances, you may even consider that those specific athletes have their own example of when the wet bulb globe temperature hits a certain amount. These are ones that you may consider holding out or playing for shorter durations of time. They essentially have their own protocol that they would follow, which may be separate from the rest of the team. What are other risk factors? Well, certainly we frequently talk about sickle cell trait. I do want to point out that obesity, as well as even an older age population. Things like inadequate sleep will also play a role in this. If you know that your players are out late at night consuming alcohol, for example, and then showing up the next morning with a minimal amount of sleep, these may be folks you may want to talk to coach about modifying the practice of the day just to help to reduce the risk of heat illness. Since 2001, when they developed the Corey Stringer Institute, we've really had a lot of great evidence coming out about, and a lot even more of research coming out in regards to heat-related illness. So let's discuss those. So heat edema, this is peripheral vasodilation of the hands and the feet. These are often relieved by elevation as well as rest, and these folks' core temperatures are normal. You may notice this, let's say you're going on a long run or a long hike, for example. You may notice, your hands feel a little bit tight, and that's a reflection of heat edema. Heat rash, this typically occurs in the areas where your clothing is located, although it may extend into other areas. It's an itchy rash. It has a papulovesicular pattern. And these folks, again, have a normal core temperature. Exercise-associated collapse. Now, this characteristically is going to be that endurance athlete, that marathoner, that triathlete who's crossing the finish line, and maybe you're covering this event. They cross the finish line, they're cheering, maybe they got a great score, maybe they got first, and they stop. And once they stop, suddenly they collapse. They were looking normal, they were not having any symptoms, but they have this, once they've stopped after crossing the finish line, all of those muscles that were previously contracting and pumping and helping to get really good venous return are now completely relaxed, and suddenly you have venous pooling down in the lower extremities, and the brain likes to give us a quick signal that this is occurring, and therefore these people collapse to the ground. Some of their symptoms may be dizziness, generalized weakness, lightheadedness, syncope. Oftentimes, either you can help them to recover by having them lay flat. You may even raise their legs, assist that the blood that's down in the venous system to get back to the heart and get pumped up to the brain. Again, a normal core temperature, once you've got their legs up, propped up, they should pop back very quickly. Now, if they don't, then you certainly do want to consider other etiologies. Exercise-associated muscle cramps. We all see this very frequently, and many times maybe the coaches are on us trying to help to do everything we can to prevent these. Now, these exercise-associated muscle cramps most often occur in the lower extremities. They do generally respond well to rest, cooling, stretching, massage, oral rehydration therapy, salt supplementation. Some of these folks may require IV fluids. And at your different schools and professional teams and the teams that you may be involved with your team physician, you may come up with a protocol regarding when you're going to utilize oral rehydration therapy versus IV fluids as your treatment. You do certainly want to consider that rhabdomyolysis may be playing a factor in these folks, particularly if they're having bilateral cramping, or maybe that cramping is extending into their abdomen, their chest, their back. They may not be responding well to either the oral rehydration or the IV fluids. You do certainly want to consider that. In those circumstances, and we'll get into management actually here in a moment, but again, these folks are going to have a normal core temperature. Now, heat exhaustion, particularly for those who are presenting to healthcare professionals, this is the most common heat-related illness. These people often do have elevated temperatures. However, they're not getting over 104 degrees Fahrenheit. They can develop physical collapse, they can develop debilitation, and it typically occurs during or immediately following exertion. There's no CNS dysfunction, so we'll talk about the difference of that in a moment. And then what are their signs? Decreased cardiac output. So these are folks, they've got an elevated heart rate, an elevated respiratory rate, low blood pressure, normal to mildly elevated temperatures we discussed. They may have some mental status changes with some irritability, some mild confusion, some agitation. Their most often symptoms are going to be fatigue, headache, nausea, vomiting, dizziness, chills, cramps. Generally, for getting them back on the field or on the court, you're going to be talking about a 24-hour time period of rest, making sure they've had symptom resolution, emphasizing good oral rehydration, getting some good nutrition into them, getting good sleep. And if you do what we do at one of the schools that I care for, if someone's going to have IV fluids done, they are going to have lab markers checked, and we do want to make sure that if they have had a kidney or a liver bump with the elevated creatinine or LFTs, then we want to make sure that we've got normalization of those biomarkers. So the treatment, circulatory airway breathing, you're going to be wanting to monitor their vital signs, making sure you're monitoring their temperature and mental status, making sure they're not decompressing or decompensating into a heat stroke. You do often want to get them into that Trendelenburg position, again, for the same reasons, the feet elevated, trying to get good venous return. Ice packs or towels. You do want to consider the ice water immersion, getting them into an area where they're going to be cool and shaded, trying to essentially just helping them to cool down, rehydrate, considering the IV fluids. So what's the difference between this and heat stroke? So that this is certainly the only one here that is a medical emergency. When you are dealing with your exertional heat stroke athletes, you are going to be activating your emergency action plan. These are ones where they have had total thermoregulatory failure. This will not reverse itself on its own independently. They have a rectal temperature that's greater than 104, and they could even be up to 107 or 108. These folks are going to be having mental status changes where the cerebellum is the most commonly affected. Cerebellum does control the vestibular system. Therefore, these people often present with ataxia. Other symptoms may be confusion, disorientation, syncope, psychosis, seizure, coma. So certainly any of these neurologic-based symptoms, you do want to consider exertional heat stroke as a potential etiology. Now, classically, they talk about heat stroke as having warm, dry skin. In our circumstances, when we're taking care of these athletes have often been exercising, right? They're going to be covered in sweat, even though they may not be creating any more evaporative heat loss through sweating. They already have their sweat that's in place, so don't let that kind of sway you from thinking that this can't be exertional heat stroke. The blood flow, their blood flow gets diverted from the viscera to the skin and the vital organs. Why? They're trying to get as much evaporation as possible, and they're trying to ensure that those vital organs, the head and the heart, are getting the blood flow. What is the issues here? Well, these folks can have then hits. These folks can have ischemia to those other non-essential organs, the kidneys, acute renal failure, acute liver failure, intestinal ischemia. And where are they sending the blood flow to? The lungs. Therefore, they're significantly increasing that blood flow amount, which is thereby causing pulmonary edema. The mortality rate here is large. And when does this occur? Most often in the first 1 to 4 days of practice. So what do we do next? We want to, again, initiate that emergency action plan. We want to be assessing the CABs and assessing their vital signs. We want to obtain a true core temperature. Now that's being done through a rectal temperature. If maybe you don't have rectal temperature monitoring, or maybe you have it available but it's not immediately available, you certainly want to initiate rapid cooling with ice water immersion. You don't have to wait for that core temperature if you're suspecting that you have an exertional heat stroke patient. What can you do? Well, once you get the core temperature monitoring available, you can certainly look to initiate that core temperature monitoring. However, it may be that maybe you don't have one. In those circumstances, maybe you're using a thermometer, and you're going to essentially, you can get a rectal temperature. Then if you have a second thermometer, you might compare that rectal temperature utilizing that second thermometer to a sublingual. Now you know at least what their core temperature was, and at the same time what their sublingual was. And then if you can't submerge that thermometer, then you can at least follow and monitor the sublingual temperatures. You should expect that 1 degree drop every 5 minutes. A minimum, if you're getting someone into those ice tubs, they should be in there for a minimum of 20 minutes. Ideally, if you have that continuous core temperature monitoring, you get them down to 102 before transporting. So what about getting these folks back to play? Again, you're going to be working together with your team physician as well as potentially other folks on your medical staff to making sure that you have normalization of lab markers. These folks can have pretty sky high elevations in their LFTs. Their creatinines can go up very, very regularly to much higher numbers. Maybe they have a baseline of 1.0, but now they're up in the 3s, the 4s, and you do want to make sure that that is trending down. If it seems to be very significantly elevated, these are the ones that are going to be staying in the hospital for a number of days, having the nephrologist consult on them and be having IV fluids, monitoring those blood work. Certainly, you're going to be going through 7 days of asymptomatic rest. Once they are being discharged and they're following up, they're having those repeat labs done very regularly. Once they have normalization of those biomarkers, now you're going to be talking about your return to play. In this circumstance, you do want to be very cautious during that return to play, progressing them over the course of the next 2 weeks. And if they have difficulty with that progression, if it's available, you do want to provide lab-based exercise heat tolerance testing to see if maybe they have some kind of underlying condition that's predisposing them to having exertional heat stroke. It is common to see hypothermia in that post-exertional heat stroke time period, as this is part of the thermoregulatory mechanism in responding. For these folks, they are generally not responding, or they're not returning to full activity until at least 2 to 4 weeks, particularly given all of the time it takes for normalization and then their return to play. They, like anyone who has a significant hit to their vital organs, their kidney, their liver, their heart, having had that, does increase their long-term mortality from organ failure. What about children? So children are at increased risk as well of heat-related illness. And why is that? Because these children, they have increased metabolic heat production, they have decreased sweating capacity. Until they go through maturity, they are going to have decreased sweat glands and decreased sweating capabilities. This decreases their ability to evaporate their heat. They also have an increased body surface area to their mass, which allows for increased radiant heat exposure and accumulation. So next we're going to talk about lightning. And this is a nice picture coming from the President's Cup in Oklahoma in 2017. The interesting thing about this picture is that there was unfortunately a soccer player who was struck by lightning, and this person was 40 miles away. So what are the lightning statistics? Florida and the Southeast United States have the highest lightning strike. So being here in Florida, this is often a topic of discussion. Most of the people who are struck by lightning survive. Many of the people who are struck by lightning do have significant amounts of morbidity. And when do we see the most lightning strikes? It's going to be June, July, and August when we have those big thunderstorms that come through. So what are we seeing here? We see a lot of blue, right? So there are more males that get struck by lightning than females. I'll let you guys try to determine why that may be. Overall, outside of 2016, what we have seen is that over time, there has been a trend through increased education to have less lightning strikes. And what are the sports that are highest in terms of getting struck by lightning? I'll let you think about that. And so those sports are going to be soccer and golf. So those are the time periods, not football, not nothing else. Those are the two biggest sports that have lightning related fatalities. And let's talk about lightning strikes. So most people don't get directly struck by lightning. The vast majority of times, someone who's been struck by lightning has experienced a side flash, which means that the current moves from the object which it strikes to a person standing nearby. How might this work? Let's say you're standing near a tree. The tree is what gets struck by lightning, or the tall pole in the middle of the field gets struck by lightning. And then maybe you're sitting for some reason at the bottom of that tree trying to stay out of the rain, and here you are, you get the side flash. Ground current effect is different, because ground current effect is like probably the video that many of you have seen where the football field was struck by lightning and immediately everyone on the field fell to the ground. So that lightning strike hit the field, the current moved through the field, through the ground, and then went up and down through the legs of all of those people who were playing the game. The only 3 to 5% are due to a direct strike, and only 1 to 2% are due to plumbing or wiring. The talk of not taking a shower is real, though you can get struck through plumbing. Wiring is going to be a little bit less common now, especially since we don't have wired phones, so we're not going to be struck that way. And then upward leaders are less common. Those are really interesting. If you want to look, you can Google some pictures of that. They're quite pretty, of upward leaders. Now, what about sheet lightning and intra-cloud lightning? These are those lightning displays that are really beautiful to look at. The big thing here is that represents a potential for cloud to ground lightning. So just because there is, many people say, oh no, that's just intra-cloud lightning, no big deal. Well, actually, it represents the potential, so this would be a consideration for removing yourself and going to a safe place. What happens when lightning hits us? Well, it's a high voltage direct current. So there's an electrical impact that occurs. There's also a thermal impact, and that refers to very high heats, upwards of 50,000 degrees Fahrenheit. This is a temperature that can melt metal. Now, this leads to those internal contusions. It also leads to tympanic membrane perforation. Finally, you have that very high visual injury. So very bright light can lead to ocular injuries. What do we find? What is that impact then on the body? Well, from the electrical impact, you can have not only asystole going on with the cardiac system, but also apnea from paralysis secondary to the medulla getting impacted. These are the most critical patients that you're going to be seeing are those with a neuro or cardiac impact. Musculoskeletal wise, when this kind of energy rips through you, it can certainly impact the musculoskeletal system. Cutaneous. So we call this picture on the right ferning. They also call it Lichtenberg figures. It is superficial. This is where the hemoglobin of those superficial vessels extravasate out into the skin. It's considered pathognomonic. If someone looks like this, they've been struck by lightning. There's no doubt about it. Sometimes I like telling people about rashes. If I expect rashes to change quickly, I said, if you like it, take a picture, right? Just like the bruising with the ankle sprain. If you like the colors right now, take a picture because tomorrow they'll be different. What do we do here? So these are folks where when we're triaging a mass casualty, we often go to the healthiest individuals first. We make sure that the walkie-talkies is what we call them, the people who can walk and talk and seem to be neurocognitively intact. Those are the folks you're going to treat first, treat and triage. Lightning is different. You want to treat the sickest people first. These are the ones who you have the biggest potential of impacting them positively because you are going to want to essentially override while their neuro and cardiac systems are currently being impacted by the electrical impulses. You're going to be overriding that with CPR and the AED. You do want to make sure that these folks are evaluated in the ER. You're going to, as part of their assessment, they are going to have a vision assessment as well as an ear assessment and that neuro assessment. And how do we prevent it? Well, we develop emergency action plans. We develop policies and procedures. We make sure that we have one available for each venue so that we know when we see lightning, who is in charge of suspending play. Is that our role? Is that the athletic director's role? Is that somebody else's role? Maybe where you're at, there is the opportunity for a lightning system that's going to be going off regardless. Once you know that the area has been deemed unsafe secondary to lightning, you want to know what is the next steps. Where is the crowd supposed to go? Where is your team supposed to go? And is that place safe? Do you have a four-walled structure that you're going to be waiting in until the dangerous conditions have passed? And where do I see this struggle with the most is going to be certainly soccer, as well as baseball and softball fields. You can certainly consider, like we talked about before, the commercially available products for monitoring. And many people, like I said, nowadays are using the telephone applications. So let's talk about viral outbreaks. Certainly the elephant in the room today, given the fact that we're moving a live webinar to an online platform. So I'm going to start with a really interesting article that was done looking at the implementation of a team illness prevention strategy. And this came from the Rugby Union Super Rugby tournament. And what they did was they looked at 3 years prior to implementing the strategy and then the 4 years afterwards. And what they were looking at was the amount of illnesses, and we'll categorize them in a moment, but the amount of illnesses and the amount of time spent away from sport that these athletes had based on those illnesses. And what was the strategy? So pre-tournament, they were screening players who are at increased risk of illness. During the tournament, they were discouraging sharing of utensils or water bottles. They were ensuring good sleeping habits, regular hand washing and or the use of personal antiseptic hand gel. Now we like to talk about 70% alcohol content. Avoidance of continuous exposure to air-conditioned or polluted environments, considering high-dose vitamin C, early reporting of symptoms, and early isolation at this onset of symptom development. And then they were also working together to look at some international travel guidelines, looking at where they're going to be going. These teams have the opportunity to travel anywhere from South Africa to Australia, essentially across the globe. And what are the common things in that area? What should they be expecting? What should they be planning for? And what were the impacts? So in these two tables here, the first one, what we're seeing is a breakdown based on the system. And what we can see on the left is we are looking at the control, and on the right, we're looking at the intervention. On the left, I want you to look at the column that starts with IR, and that refers to the incidence rate. If we compare that incidence rate to the incidence rate of the control to the incidence rate of the interventions, what we see is there is nearly a 50% reduction across all of those values. The same thing is true when we're looking at all infections. So if we look at them based on all infected illnesses, so looking at all infections and then thereby categorizing them again based on the different types of infections that may be occurring. What interesting thing to note here is the most common type of infection that we would be seeing is a respiratory related infection. Followed by, then if we're looking at it from a system perspective, we're talking about digestive tract issues, followed by skin and then ears and so forth. And what is that illness burden? So all illnesses, what we were seeing is between the control and the intervention, we were seeing that the illness burden decreased as well. And this we would expect. The amount of days lost are going to be less if the amount of people that are getting sick are less. So this implies that we can institute together protocols and programs such as these. We can educate the athletes that we're working with, because we're all traveling together, right? We're traveling on airplanes, we're traveling in buses, and we don't want to get sick either, and we don't want our athletes to get sick. And we know that these interventions will reduce the rates of illness. So what else is going on in the world? Well, right now, many of you guys are either being assigned, reassigned, redeployed. Some people are finding positions. Maybe those event outreach positions are no longer occurring. And so you're looking for other job placements. Maybe you're looking at the different online application platforms that provide easy access to job postings, and those are starting now to show hospital positions. Maybe you're working in a triage setting. Maybe now you are helping your clinic or hospital system to triage these patients to determine who should be tested, who should be quarantined, and how best to manage this influx of patients who are coming in, particularly with respiratory illnesses. So let's talk about the coronavirus. What size is it? It's 120 to 190 nanometers in size. This works out to be 0.12 microns, and this becomes relevant when we get to, and we're going to get there, talking about masks. Now, COVID-19, what do we know now? COVID-19 is stable in aerosol form for 30 minutes and on many surfaces for 2 to 3 days. And that helps us to better understand how to prevent and decrease the rates of transmission. What else do we know now? Well, the coronavirus is shed during respiration, toileting, fomite contact, which refers to the transmission via inanimate objects, indicating that infection may occur in both direct and indirect ways. So masks, we're seeing a huge surge, certainly in social media and other locations, of masks being created. And many of these masks are being created with the resources that are available. And for many folks, that's going to be cloth as the component. What do we know? This virus penetrates cloth masks. So if you are in a setting where you're doing the triage, where you're working in the hospital, where you're working in the clinic, a cloth mask is not a good option for you. Certainly if people are out in the public and in other non-healthcare related settings, this is fine. But we know sweatshirts, t-shirts, towels, scarves, cloth masks, we are having penetration of particles that are in the size of this virus. So these cloth masks are not in isolation a good option. But what are? Surgical face masks. So surgical face masks are a great option at reducing the virus shedding. So who can utilize these? Well, healthcare, we as healthcare providers, we can utilize these, and we can also utilize these for our patients, trying to help to reduce the amount of viral shedding going on with wherever these people are in their homes or in the clinic or hospital systems, trying to reduce the amount of cleaning that we're having to do to reduce the amount of transmission. So we do know that wearing a surgical mask is going to be beneficial, and particularly beneficial for those who are sick. Now, what else should we consider when we're wearing these masks? That these masks can get contaminated. So if we're not using the mask for our patients and we're using the masks ourselves, and maybe in our system we're running low on the amount of PPE, and so we're having to reuse these masks, and maybe we're having to take our breaks, our food breaks, our lunch breaks, whatever that may be. Maybe we're having to go on our lunch break and then come back and use these masks again. If you are in a healthcare system where you're taking care of these patients that are known to have coronavirus infection, then you want to make sure that you have a safe and appropriate plan in place on how you're going to protect your PPE so that you can protect yourself and your family. Now, in terms of what other types of ways can we help to prevent the spread for us and our families, is going to be heat, thermal. So let's say we know that at 56 degrees Celsius for 25 minutes and 65 degrees Celsius for a minute, these are important numbers to know when it comes to our clothing, to the things that we're wearing. We want to, once we get home, we do want to make sure that we're disrobing our clothing that we've been spending all day triaging all of these sick people. We want to disrobe that clothing and get it into the washer and dryer. That will be effective. We also know that if there are tools and utensils that we are going to be reusing, from a temperature perspective, we want to be using either a thermal or a chemical way of disinfecting that equipment. What else? A dilute bleach solution that will effectively kill the virus. Now, that does imply that there are a lot of cleaning companies that have now just exploded with the amount of need that there is for them out there. They frequently do use bleach solutions, and they're now utilizing increased amounts of the sodium hypochlorite for their bleach solution and coming to these hospital systems and to these different facilities and enhancing their cleaning techniques. What about the other do-it-yourself masks? So if you are not utilizing cloth, you're not utilizing these very permeable substrates, these components for your mask, there are potentials of utilizing other components to be able to create the masks, and you're getting appropriate amounts of filtration. This is especially going to be helpful if you're in an area where you are low on PPE. I certainly don't have the sewing skills to be able to make these kinds of masks, but if there is someone available and there is a need for it, this would be a good way of redirecting the population, those people who are at home right now and not sure what to do. This is a good way to be directing them to make things that are going to be effective for you to be utilizing in that healthcare sick setting. And what are some of the other options? Now, in the top picture, what you're seeing is they have come up with a rubber band mechanism. They call it Fix the Mask. And if you again search that on Google, what you'll find is that there is a way to adhere that mask so that it more closely approximate the shape of your face to help to reduce the amount of virus coming into contact with your mouth and nose. So that's the first picture. And then the second picture is certainly the mask being created from these higher filtration abilities of tools. So with that, I would like to thank you for your time. I want to let you know that we have many more additional opportunities going on. We're continuing to develop those opportunities for live CEUs through the BOC. We're continuing to do it at a great price of free. If you're looking for what those upcoming topics are, you can go to our website. You can also go to the BOC website and those will get posted. The next webinar is going to be next Wednesday, April 15th at 6 p.m. We're going to have Dr. Pilkington talk about the urologic considerations in the athlete. At this point, I am happy to take any questions.
Dr. Henne, we did have a question here about making masks at home, in particular from a neoprene mask from a koozie. Can you answer any information on making home masks out of koozies with neoprene material?
Well, that's interesting. So there are a lot of different types of materials that people are using right now to make masks. One thing you do want to consider is what one is going to be the comfort level. I'm sure many of you have seen the pictures of people when you're having to wear these masks. Potentially, if you're going to the point where you're using a personally made do-it-yourself mask, hypothetically, you're doing this in a situation where you don't have surgical masks, you don't have N95 masks available, and you're looking for the next best alternative. What you do want to do is you want to look for materials that are less permeable, but you do still need to be able to breathe through them. And then another consideration, if let's say you do have a very nice person who sits down and makes you a bunch of cloth masks, one consideration for utilizing that is if you have an N95 mask or a surgical mask and you know that you're going to be having to wear this for your entire shift, you could consider putting one of those cloth masks over it. And then as you go from patient to patient, that can be a good time to be changing out those masks. Certainly if it's cloth, you can bring it home, wash it, and then reuse it the next day. I'm not sure exactly kind of visually what you're referring to with the neoprene and koozie. I will say that those, if you want, once the webinar gets posted, those links that I have posted along with those pictures are links to masks that have been studied in the transmission of this virus. So one of those that comes to mind is the UF anesthesiology group that did that study.
Our next question is, does the use of 70% isopropyl alcohol sprayed on the mask help disinfect it?
That's a good question. And so one of the things that we know is that, yes, that has been published, and that is information that is accurate. The isopropyl alcohol at the 70% level does help to kill the virus that's there. Now, in terms of spraying it directly onto your mask, you do want to ensure that you are maintaining the integrity of the masks. Some masks are going to be able to support spraying better than others. If you have the opportunity, you can do one of those a little bit larger clear plastic covers that are kind of more of a face cover to help to prevent direct virus and direct exposure getting onto your face mask. Another way to do this would be to essentially to discuss with your health system. And there are ways where you can store your mask. They have been doing it in things like paper bags where they have a known side. This is the side that your mouth goes on. This is the side that's going to be out to the public. This is going to be the side that's directed towards the sick people, so that at the minimum, when you're putting your mask on, you're applying the clean side to your nose and mouth, and then the opposite side is addressing those sick people.
Our next question is, do you have any suggestions for acclimatization for athletes that have to work in hot conditions? So maybe not so much an athlete, but if an athletic trainer is working in an industrial setting or taking care of firefighters or Army or anyone like that, and they can't escape or postpone their work due to heat or humidity. Do you have any suggestions for acclimatization for them?
Gotcha. Yeah. Well, one of the easiest ways to do it is going to be starting if they've already recovered, they've had normalization of their lab markers, and they're starting their return to activity protocol. You do want to start with a lower thermal load. And what can that look like? The firefighters, the Army military personnel, there is the option for them to be able to do this indoors. So if you can get into a climatized environment and you can control that climate, you're going to be able to get them doing activities in the climatized environment, in that AC environment. And what you're doing is you're essentially restarting, making sure that their evaporative thermoregulatory components are working, because it's going to take everything kind of has been done into overdrive. It will take time, but I would say that starting in an AC environment is going to be best. You can utilize things like a stationary bicycle or a treadmill. Get them moving, get them increasing their heart rate, get them increasing their cardiac output, and start there. From there, let's say you have them do that for a few days, and you're able to increase their intensity, increase their duration. And then at that point, you're saying, okay, they've done well with this. They haven't had any additional heat issues. Now let's progress them. Let's increase that thermal load. Each time you increase the thermal load more, you are going to want to expect to bounce back on what you were able to do in terms of intensity, duration, or distance. So let's say you did whatever it may, you can always work with your team doc, or maybe the physician who is involved with that care if it's not an athlete per se, but work with that physician to develop what that plan can look like. Start with that first period of time doing it in a low threshold environment, and then slowly increasing that threshold.
Okay, the next question here is, if a patient gets struck by lightning, will the athletic trainer or the first responder be at a risk with immediate treatment of getting shocked or anything at risk there if they were to provide immediate treatment from someone who was just struck by lightning?
So that is a good question, because we all certainly want to, we were all taught from the beginning scene safety, right? So what we know is that it is safe to approach someone who has been struck by lightning. They do not carry an electrical charge. So therefore, you coming into physical contact with that person who is at this point, assuming you're going to be approaching that sickest person, that person who appears unconscious, they're not moving, that's the person you want to attend to first. You're gonna assess their airway, breathing, circulation. You're gonna see if they've got a pulse, and if they're not breathing, then at that point you're gonna initiate CPR. And you will not be injured by directly coming into contact with them. That's a great question.
Another question about lightning. Do you have any recommendations for lightning detecting products? And also, what is your recommendation for lightning distance?
Yes. So, well, in terms of the distance and whichever boards you're taking, one thing that we know is that we cannot resume until 30 minutes after the lightning and thunder have separated the area. Now, from a distance perspective of when to suspend activity, I will say that there's some differences in that depending upon which league or organization you're involved in. So they all come up with their own protocols. Sometimes I think there's an attorney or someone who is helping to direct those numbers, but whatever it may be, you do want to check if you're going to be doing event outreach with an organization that you haven't worked with before and it's an outside activity. You do want to check what is that organization's protocols for stopping based on lightning. And I bring that 40 miles up because it's definitely rare for someone to be struck from 40 miles away. We frequently utilize 10 miles, and many of us have different apps that are helping to identify if a storm cell is getting closer, so that we can be anticipating the stoppage time, the suspension of the game. And then from an application perspective, I certainly, based on the BOC, I can't recommend anything in particular. There are different apps that are out there. One that comes to mind is Weather Sentry. It's a paid for application that will notify you. We all have our phones on us, and you can preset where your comfort level is on what your diameters are for how far you want to be notified when there's lightning in the area. Me personally, I tend to like to know when it's pretty far away, but that does mean that I get a lot of notifications at various times.
And the last question here is, what is the infectious dose of COVID-19?
It's from the perspective of a virus. At this point, we don't have that specific information for coronavirus. What we know is that it is certainly very contagious. There is the potential for aerosolization. There is the potential of transmissions via fomites. So if you are working in that setting, I do want you to be very cautious. Make sure that you're protecting yourself. Make sure that you're continuing to clean those surfaces, so that once we've flattened the curve and this is behind us, we are all ready to go back to all of the wonderful sports and things that we enjoy participating, watching, sideline covering, and all of that great thing, great stuff. All right, have a great day.